I'm Norman Daniels, currently Director of the Program in Ethics and Health, and I'm a member of the Global Health and Population Department at School of Public Health. So it's my pleasure to welcome you to this 7th annual conference of the Program in Ethics and Health. And as you know, the topic for this year, otherwise you probably wouldn't be here, is the identified victims or identified lives versus statistical lives. And it's a cross-cutting issue that shows up in many areas of health policy. I hope I'm not speaking only for myself when I ask how many here remember the baby Jessica who fell in a well in Texas in the late 80s. There are some of us in this room who do remember that and others who maybe weren't born yet. But nevertheless, in some ways that was my introduction to this issue on a large scale. So baby Jessica fell in a well in Texas. And there was enormous media attention to her rescue of the sort that we saw with the Chilean miners recently. Americans around the country contributed $700,000 to her family for her support after her rescue. But nobody talked about well safety in a significant way or the contributions that might be made to saving lives by capping wells. So you prevented that sort of an issue around Jessica. This may be indelibly put in my mind. I was already teaching and thinking about these issues. The whole topic of this conference. So I see it as a cross-cutting issue that shows up in many areas of health policy. I think we saw versions of it in the scaling up of antiretroviral treatments around the world for people with AIDS, because when that was promoted as a rectification of the policy that primarily focused on some somewhat ineffective treatment measures around the world. There were pictures of patients who were in need of this treatment and who then had robust revivals of their capabilities after treatment. And this put in the public's mind the idea that you could actually do something about this epidemic, and that may be a version of the identified victim issue. My sense is this is a very large cross-cutting problem, and personally, although I started to think about this when the Jessica fell in the well in Texas, it was when I first came to Harvard or was thinking about coming and was talking to people who were interviewing me. They asked what kind of an issue did I want to work on. And I said, well, one that comes to mind is this problem of identified versus statistical victims. It didn't happen for about 6 or 7 years until I had a sabbatical a few years ago, and then I began to read a lot of the literature on this, and that was the point at which I became aware that Tom Schelling, who's on our speaker list for this morning, was probably the person to first identify the issue in the literature. And another Harvard colleague, Charles Fried, wrote a seminal article on it in 1969 in the Harvard Law Review. Basically, it was not an issue that has been significantly addressed in the literature until the late 90s, when some decision scientists, Deborah Small, who's also on our speaker list for this afternoon, and collaborators also worked on this issue. We will have a session later that focuses on some of the triggers for this problem. So I feel very pleased to find the interest in this issue as reflected in the wide sponsorship and co-sponsorship of this event. I see this as a very large cross-cutting problem. Sometimes it's identified as the problem of the difference between public health and medicine. That may not be an accurate way to describe the problem. Sometimes it's seen as the gulf between prevention and treatment, and I think that too is criticizable as a contrast that completely reflects this difference. Nevertheless, it is an issue that we encounter in the public and public attitudes towards health and health policy in many dimensions. And so I want us to explore this together over the course of the next 2 days, today and tomorrow. To begin the effort of exploring this together, I have invited several very prominent people to speak this morning and help us frame the question, because it's not always clear exactly what the issue is. And I'm hoping that the insights that several of our morning speakers bring and the discussion that they encourage us to engage in after they speak will produce some better understanding of the issues that we will try to disentangle over the course of the next 2 days. So the organization of the conference is that after this morning session focused on framing the problem and distinguishing some of the elements of the problem, we will move to a discussion of some of the social science investigations of what triggers the problem, what are some of the accounts that are in the literature about why we behave the way we do. And later this afternoon, we will have a session on a new strategy for addressing some of the problems of HIV/AIDS, and we will focus on the test and treat strategy, which the organizers of the conference saw as having at root some of the kinds of issues that might be raised by the identified versus statistical lives problem. Tomorrow, the conference reconvenes in Cambridge. I should mention that the organizer of the session, the first session this afternoon on decision science, is Steve Resch, who's here. He represents the Decision Science Center, which is one of our co-sponsors. Another co-sponsor is the Petrie Flom Center, and the session tomorrow morning is organized by Glenn Cohn, who is sitting in the third row here. And Glenn is a co-director of the Petrie Flom Center. The session late this afternoon is largely organized by Nir Eyal, who focuses on, as I said, the test and treat strategy. Tomorrow afternoon, there are 2 sessions on the normative implications of this issue, and Nir and I helped organize those sessions, and I appreciate all the speakers for participating in this conference. Other co-sponsors of the conference, reflecting the very broad cross-cutting nature of the problem, are the Population and Development Center, and especially the Population and Development Center at Harvard. So Safra Center for Ethics is a significant contributor, and I particularly would like to thank Sue Goldie as director of the Global Health Institute, which has supported this effort not only through its provision of staff to do the logistics, and I particularly want to thank Jeannie Austin and Nicole for their organizational efforts, but Sue Goldie for contributing significantly to the funding of this conference, which wouldn't have taken place in this scale without that effort. So I wanted to thank all the co-sponsors of this event before I introduce our speakers. Let me begin our first session, which will focus on the framing of the issue. The format for this session is that each speaker will speak. I'm going to break the format slightly to accommodate the fact that Sue Dentzer, who is our first speaker, has got to catch a plane to go to New Mexico for other events today. And so what I'm going to do is ask her to speak for a while and then field some questions, because she won't be able to participate in the panel later this morning in order to catch that plane. So let me say a few things about the speakers. So Sue Dentzer, who starts our session, is the editor-in-chief of Health Affairs, as many of you know. And this is, of course, the nation's leading peer-reviewed journal focused on the intersection of health and healthcare and health policy in the US and perhaps internationally. Her background is as a highly respected journalist and policy analyst who appears regularly on talk shows and news programs, and who has a long history of prominence in the media. She's also a member of the Institute of Medicine, the Council on Foreign Relations, the National Academy of Social Insurance, and she's a fellow of the Hastings Center, and I think we first met at a Hastings Center event. She's also an emerita trustee and former chair of the Board of Trustees of Dartmouth College, where she received both her undergraduate degree and an honorary degree as well. So we're hoping that she will frame the way in which the identified versus statistical lives problem arises in several areas of health policy. What I'm going to do is introduce the other speakers also briefly this morning, and then we can proceed in the session without further interruption. It's my great honor to present Tom Schelling, who will appear second in this session. Tom was awarded a Nobel Prize in Economics in 2005 for his work on conflict and cooperation. He participated early in his career in the Marshall Plan in Europe, and later worked at RAND, where he developed the concept of a probabilistic threat. His path-breaking work on nuclear confrontation and strategies for conflict and cooperation are reflected in his one of his major books, The Strategy of Conflict, and then a later book, Arms and Influence. And later in his career, he addressed issues of racial stratification and more recently, global warming. I say more recently, but this may be, he was thinking about this issue long before it became a hot topic. And in the early 80s, I believe, first addressed some attention to it. So you can see the connection between his work on cooperation and the issues around global warming, if you think about it for a second. To my knowledge, he is the first person, as I said, to identify the identified versus statistical lives problem and in the literature. in the late 60s. He holds a distinguished professorship at the University of Maryland, which he took up after 31 years at Harvard in the economics department and also the Kennedy School. He retired from Harvard in 1990, and it's wonderful to have someone back who has thought out of the box for so many years to help us frame this issue. So I look forward to Tom's remarks. David Cutler is a colleague of those of us on the Harvard faculty. He's the Otto Eckstein Professor of Applied Economics in the Economics Department and in the Kennedy School of Government. So he's at KSG a little after Professor Schelling was. And he completed 5 years as Associate Dean for the Social Sciences at FAS recently. In his earlier stages of his career, he served on the Council of Economic Advisors and the National Economics Council under President Clinton, and was senior healthcare advisor to the Obama presidential campaign. And I think he'd be the first to say that he didn't coin the phrase Obamacare, though he contributed many ideas to the health reform.
I proposed Cutler Care, but
Cutler Care, nobody, it didn't sell. So he is a member of the Institute of Medicine. His book, Your Money or Your Life, Strong Medicine for America's Healthcare System, is a well-received landmark in the field. And I'm hoping that Professor Cutler brings his insights on health system design to bear on this identified versus statistical lives problem that we're addressing today. And last but not least in our list of morning speakers is Dan Brock, who's the Francis Glessner Lee Professor of Medical Ethics in the Department of Global Health and Social Medicine at Harvard Med School. And he's the is it former or director of the Division of Medical Ethics? Still, okay. And former director of the Program in Ethics in Health. Prior to that, he was a senior scientist and a member of the clinical bioethics department at the National Institute of Health. And even before that, and for a long period of time during which I first met him, he was at Brown University, where he ended up the Charles Tillinghast University professor and professor of philosophy and biomedical ethics. And he was director of the Center for Biomedical Ethics at Brown. He served as a staff philosopher to the President's Commission for the Study of Ethical Issues, Ethical Problems in Medicine in the early 80s. This was in the transition from President Carter to President Reagan. And one of the stories I've heard about that episode is that the word rights to healthcare had to disappear from the language of the reports in that transition. In any case, he helped work on many of the documents that were produced by that commission. He's also a fellow of and former member of the board of directors of the Hastings Center. He's written very widely on bioethics, where he's known for bringing rigor to the subject. And his task this morning is to help us frame the issue of the conference around the normative issues raised by this problem that we're all addressing. So with no further ado, let me welcome Sue Dentzer to the podium, and we can, the format will be after she speaks, she will field a few questions, and before we move on to Tom Schelling. Thank you. That's your remote.
Thank you very much, Norm, and good morning. Thank you for giving me the great excuse to come back to Harvard. I was here years and years ago as a Nieman Fellow. Actually got to go hear Tom Schelling sit at his knee and learn deeply from him. David Cutler is a member of our editorial board, so I get to see him from time to time. But as I say, it's great to be back in this neck of the woods. And frankly, as the editor-in-chief of Health Affairs, since I spend most of my days editing articles about Medicare's sustained growth rate formula and other arcana of finance, this is a real treat, Norm, to be able to talk about this subject. For me, it's kind of like a day at Fenway Park. You know, it's a break from the usual. So thank you for giving me that very welcome break. Okay, great. Well, depends on the year, right? Depends on the year. So my topic, obviously identified versus statistical lives. I'm going to focus on some contemporary issues in health policy, really contemporary, like now, and I'm going to focus on just a few examples in which I think some of these issues come up. In particular, and obviously I have to say they're coming up again because people like Tom will recognize we've been dancing around these things for many, many, many years, if not decades. And I think in particular in the current context, we see them come up not just in the context of identified versus statistical people, but it's also in the US context, it's me versus everybody else also. So you'll hear some themes around that. Do I care about me or us? And it's inevitable that in the US context, this notion of the identified individual comes very close to our notion, we morph very quickly to a discussion around individual rights. It's not just me, it's my rights. Now, granted, we may not have gotten there in healthcare, rights to healthcare, but rights to everything else, we're very quick to claim. So the rights or the needs of the individual versus the whole. And obviously, the population focus in health versus the patient-centered focus, I think, remains alive and well. And I would argue we're even sort of drifting, if not being tugged even more in the direction of that person-centered focus. And I'll offer a couple of examples, I think, that illustrate that, this constant tug that we almost can't get anything done unless we tug it back into the issue of the patient, the individual, et cetera. The three examples I'm going to talk about are the current, actually that's legislative, I should have said the court challenges to the Affordable Care Act, but there also, of course, are legislative challenges in the form of bills to repeal the Affordable Care Act. Some of the debates going on now over various screening recommendations coming out of the U.S. Preventative Services Task Force and the recent episodes where we've seen the task force make recommendations that then get a lot of blowback. Also, I'll talk a bit about the Patient-Centered Outcomes Research Institute versus the mass notion of comparative effectiveness research. And again, I think you'll see this constant tug back toward the individual because we can care about the individual, particularly if the individual is us. So I always remember this famous quote of George Bernard Shaw: "It is the mark of a truly intelligent person to be deeply moved by statistics." By this standard, I don't think we're so intelligent here in our context of U.S. health policy. The statistics just do not move us very much. It's more the individual. And then the other famous quote, this one attributed to several people, but I guess most recently to Irving Selikoff, the epidemiologist: "Statistics are human beings with the tears wiped away." We almost cannot care about the statistics until we until we basically focus on the tears and the individual. We just cannot get that motivated to do much when it's about a mass group of people. So to talk about the court challenges to the Affordable Care Act, and again, the notion of the identified individual, I think as those of you who listened to the oral arguments or read the accounts of the oral arguments just last month before the Supreme Court heard a lot about the identified individual, mostly being that person who doesn't want to be forced to have health insurance, but is subject to the individual mandate, or the person who's afraid that the government will make him or her eat broccoli. That came up over and over and over again, versus the statistical masses, the estimated 32 million people who will gain coverage, most of whom are low income. And the competing efforts in the oral arguments that we heard to claim the right, but also to try to own the concept of liberty. Whose liberty are we talking about here anyway? And you heard this in particular in some of the exchanges involving Justice Scalia, who said to the Solicitor General, who was arguing the case for the administration, Don Verrilli, the argument here is that people were left to decide whether they want to buy insurance or not. These people are not stupid. They're going to buy insurance later. They're young and they need the money now. So, we have to be concerned about the rights of these poor 20-somethings, 30-somethings who are just scraping by in the in the new startup that they hope will turn into the next Facebook, and can't afford to buy health insurance, and they're going to get it when they need it. So Scalia basically demonstrating his deft understanding of the way the health insurance market works. You just buy it when you're about to get sick, et cetera. General Verrilli tried to respond, I should say, but then Scalia went back and said, when they think they have a substantial risk of incurring high medical bills, they'll buy insurance like the rest of us. So this individual, the individual right, this is what the mandate is going to contravene. When the arguments were closing on the third day, and this was after the discussion about the Medicaid expansion and whether the proposed Medicaid expansion or planned Medicaid expansion was unconstitutional, General Verrilli did something very interesting. He was trying to appeal to the liberty-loving instincts of the justices, and in particular Justice Anthony Kennedy, who has written a lot and cares very deeply about individual freedoms. And so Verrilli, rather than sort of making the argument, we got to care about the masses, and compassion and all of that, said, there's an important connection, a profound connection between the lack of health insurance and liberty. In this population of Medicaid-eligible people who will receive health care that they cannot now afford under this Medicaid expansion, there will be millions of people with chronic conditions like diabetes and heart disease. Okay, so we're starting to talk about the masses, the statistics. But then, as a result of the health care they will get, they will be unshackled from the disabilities that those diseases put on them and have the opportunity to join the blessings of liberty. The same thing will be true for a husband whose wife is diagnosed with breast cancer, who won't face the prospect of being forced into bankruptcy to try to get care for his wife and face the risk of having to raise his children alone. So it was very interesting to hear this. Unless we can push it back into the notion of a personal liberty, it's my personal liberty, it's my right to be free of disease, we couldn't quite make the argument that was going to be satisfying to at least one of the justices, if not more than one of the justices, who will be deciding the fate of this law. So once again, I think you can see that tug pulling through. The other, I mentioned the second example I wanted to talk about was this notion of the U.S. Preventive Services Task Force recommendations on screening, which are always, of course, mass recommendations. It's basically, should we recommend screening for a broad group of people? And of course, the Preventive Services Task Force goes through all of the existing medical evidence and makes a proposal one way or the other. When they have made proposals recently or revised other recommendations recently around breast and prostate cancer in particular, they have gotten, as you know, just incredible blowback, partly because of the way they have communicated those decisions, which has not exactly been the state of the art of communications. But a lot of the pushback, it always comes, and why are you telling me that this is what I should have? Why are you making this mass recommendation that might be fine for everybody else, but it doesn't speak to my personal need and my personal risk? So if you look at the way, for example, in the fall of 2009, when the task force first came out with its recommendations to alter its recommendations on mammography screening for women below the age of 50, the first iteration of it was not recommended for women below the age of 50. Not recommended, no evidence that it really saves lives. And there was an amazing blowback. And in fact, of course, Secretary Sebelius stood up and actually disowned that recommendation, said that's not what we want. When they came back with a modified language on the recommendation, it was women in their 40s should not get routine mammograms for early detection of breast cancer. Screening mammograms before age 50 should not be done routinely and should be based on a woman's values. So we had to immediately personalize it. This is the mass recommendation, but you have your own values. And if your personal value is that you want to make sure that a test that we don't really know finds what it should find, if you really want to have that anyway, and that's your value, you can have it. And this is the way, and there were similar things done to try to modify prostate cancer screening recommendations as well. So again, sort of pulling us back to the personalized route. So let's see here. Let me move on. The third example of this, I think where we see this in spades, is in the context of putting in place the comparative effectiveness research agenda that is inherent in the Affordable Care Act, and tying it to the debut of this new organization, the Patient-Centered Outcomes Research Institute, which many of you who have followed the debate know. The PCORI, as it's called, had to be set up as a non-governmental entity. It's an extra-governmental entity. It's a nonprofit because we couldn't house inside the government something that would make any kinds of recommendations anymore about what people should get in terms of health care. So PCORI is separately constituted. In the law talked about this need to do comparative clinical effectiveness research, research evaluating and comparing health outcomes and clinical effectiveness, risks and benefits of two or more medical treatment services, items described, blah, 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 blah. The medical treatments described in this subparagraph, healthcare interventions, protocols for treatment, care management, delivery procedures, medical devices, et cetera, et cetera, et cetera. So the language is all about this sort of the mass of care that we will provide to the mass of people, and comparing head-to-head in some cases in clinical trials, does drug A work better than drug B, developing that whole basis of understanding. Very important agenda, obviously, since, as the Institute of Medicine has noted, we lack medical evidence for about 50% of what we do in healthcare. About 50% of what we do has essentially no evidence that it works or doesn't, so this is a very important agenda. Now, if you look at how this has been refined by PCORI going forward, PCORI recently, actually, here's the description of PCORI in law. The purpose of the Institute is to assist patients, clinicians, purchasers, policymakers in informed health decisions by advancing the quality and relevance of evidence concerning the manner in which diseases, disorders, and other health conditions can effectively, appropriately present, diagnose, treat, et cetera. Again, a sort of a overall description, overall approach. When we go to what PCORI has said it is going to do, this is PCORI's mission statement, recently finalized and announced. And here's how PCORI describes what it is it's going to do. We help people and their caregivers communicate and make informed healthcare decisions, allowing their voices to be heard in assessing the value of healthcare options. This research answers patient-centered questions such as, given my personal characteristics, conditions, and preferences, what should I expect will happen to me? What are my options, and what are the potential benefits and harms of these options? What can I do to improve the outcomes that are most important to me? How can clinicians and the care delivery systems they work in help make the best decisions about my health and my health care? Now, partly this is an effort, obviously, to communicate very directly to individual Americans. That's good. It's also an effort to insulate the PCORI from the political pressures that preceded the enactment of the legislation, where those of you familiar with this will recall this huge battle that took place over, are we going to have another organization here, just like NICE, that's going to do cost effectiveness assessment and tell people, sorry, that care is going to cost us too much. You're not going to get it. There was so much pressure on the other side that that's actually how the PCORI got housed outside the government. That's why it's called the Patient-Centered Outcomes Research Institute, not the Comparative Effectiveness Research Institute of America, et cetera, et cetera. So this is partly political positioning, but again, I would suggest mostly it's about tugging it into a context that can be politically acceptable for Americans and seem relevant to Americans, and frankly, me is relevant, you are not, or they or us are not. So where do we go with this? This is a famous, breast cancer T-shirt that you see around, particularly around times of the breast cancer marches in Washington. I'm a survivor, not a statistic. Now, part of that is, of course, the statistic implies death, so I don't want to be a death statistic. I want to be a survivor. But also, I think there's more going on. It's I am me. I made it. I survived. I'm not going to be a mass. I think that there's an undertone of that to this symbol. And I would say, to put it back into our long-standing U.S. political context, I hearken back to Joe Ellis's great book, Founding Brothers, where, as those of you who read it know, he makes a lot of this, what he calls the central contradiction on which the U.S. was founded, which is, are we a nation about the rights of the individual, or are we a nation about the solidarity and well-being of us all, and a coming together to create a new social context for all, liberty and justice for all? And as he says, we as Americans kind of constantly bounce back and forth between, who are we and why are we here? Is it that we're about that individual, me? Is it about the well-being of us all? I think that is the central political context in which we continue to sit and where we continue to have a lot of these discussions and debates about what should happen in health policy. So with that, let me stop and take my little 5 minutes of questions here. Thank you very much.
Okay, the procedure would be if you have a question or comment, please come to the mics and we'll take you in order. So you'll be your own definer of order by how fast you can run to the mic.
So you mentioned that 50% of what we do in healthcare, we really don't know what we're doing. Part of that, of course, is because all of that comes from clinical trials, which are sponsored by the drug industry, and I'm part of the drug industry, so I'm sensitive to that. And those are trials which are, by economic necessity, going to be limited. So in some ways, the present deal that society has with the drug industry is, in a sense, the worst of all possible worlds, because it doesn't really deal with the individual on the one hand, but can't possibly generate statistics that are meaningful and significant for the broader, to actually be able to come up with these answers. The P-Corey concept might move a little bit in that direction, but it would really be better if, in fact, everything that were approved were able to generate sufficient numbers. And economically, that can't really be done unless the individual ultimately, at some point, concludes that if you take a foreign chemical substance, particularly, there's a risk associated with it. And implicitly, society seems to feel that their medical treatment is going to be completely risk-free. And there are consequences to that, which I would like to hear your thoughts on.
Well, no question about that. And I guess that gets somewhat off into the realm of perceptions about risks and just basic, frankly, classic American understanding of what if you introduce something into the body, obviously things are going to happen positively, but possibly negatively as well. To go back to the drug development and drug approval piece of it, though, I agree with you, and I think that the point of Joe Selby, the head of PCORI, who was at Kaiser Permanente conducting a lot of Kaiser Permanente's comparative effectiveness research, talks about how what was constantly frustrating to him as a clinician was that he would read these results of clinical trials, and they would be exactly as you said, they'd be based on 2,000, 4,000, 5,000 patients, very, very carefully selected patients to meet the criteria of the study. And would produce results that did not speak to the actual patients that he would be seeing. They didn't have comorbidities. They didn't really give him much to go on, what to tell a particular patient to do. And so in the best of all worlds, comparative effectiveness research going forward will be able to do that. And PCORI has made a lot about looking at subpopulations of patients. Are the results the same for patients with these two comorbidities, or are they the same for across racial or ethnic groups? So that's all quite positive. And then overall, we are moving to the direction of understanding, I think, that what we probably should do is approve drugs a little bit sooner if we can, get them out into the marketplace, and then watch them like hell as they are rolled out across large populations of patients, because then you have a big enough pool statistically to see what the effects are. So I think we are moving positively in that direction. So the policy in that respect is appropriate. How we couch that to individuals, how we sell that to individuals is all about me. It's all about the personalized medicine piece. So leaving aside not being able to answer the question about risk perception, I would just leave it at that. So.
Thank you. A practical question. Who will pay for that woman that below 50, that because of her value, he want to have a mammogram, and that it would not be indicated according to the recommendation?
Right. Excellent question. And the Preventive Services Task Force is, like most of these organizations, not supposed to take cost into account. So it didn't, and it didn't even in its modified form. It is also, I should also say, the American Cancer Society and other guidelines continue to recommend routine screening for patients 40 and over. So most insurers are continuing to cover that for women. So effectively, we are all continuing to pay for that through insurance premiums. It's just incorporated into the cost of insurance premiums. So that's the way we've decided to deal with that one, which is basically say we're going to cover it because some people think it's going to be done, and politically we're not willing to argue that it shouldn't be done. By the same token, I think even proponents of even Otis Brawley at the American Cancer Society wants desperately for us to find better methodologies than mammography screening. But for now, that's what we're doing. We're doing it and we're paying for it.
I think I'm here more for ceremonial reasons than intellectual, because Norman Daniels mentioned that I was one of the early recognizers of the distinction that is the basis for this conference. And that was a long time ago. I wrote something, and I'm going to quote a paragraph from what I wrote. But first, let me ask, the chapter of the title of the chapter in which I wrote this was "The Life You Save May Be Your Own." How many of you remember that slogan? Yeah, not quite everybody. That was a much advertised slogan. I think it was Metropolitan Life, which was trying to explain to people that they had an interest in longevity because they have to pay out when people die, so they're happy when people live longer. And they were trying to explain that people should support their effort, whether it had to do with regulation to save lives or whatever it was, or spending public money to save lives, that they wanted people to know that their own lives might be among those at risk. Well, what I wrote was this: there's a distinction between individual life and a statistical life. Let a 6-year-old girl with brown hair, Jessica in the earlier statement, that a 6-year-old girl with brown hair needs thousands of dollars for an operation that will prolong her life until Christmas, and the post office will be swamped with nickels and dimes to save her. But let it be reported that without a sales tax, the hospital facilities of Massachusetts will deteriorate and cause a barely perceptible increase in preventable deaths. Not many will drop a tear or reach for their checkbooks. John Donne was partly right. The bell tolls for thee, usually if thou didst send to know for whom it tolls. But most of us get used to the noise and go on about our business. How many of you remember John Donne? Yeah, he was an early 17th century English poet. And in 1624, he wrote, and this is frequently quoted, "No man is an island, entire of itself. Every man is a piece of the continent, a part of the main. If a clod be washed away by the sea, Europe is the less, as well as if a promontory were, as well as if a manor of thy friends or thine own were. Any man's death diminishes me, because I am involved in mankind. and therefore never send to know for whom the bell tolls. It tolls for thee. How many of you remember For Whom the Bell Tolls? This was a book by Ernest Hemingway, published in 1940. It was a great book. It was a tragic book based on the Spanish Civil War of the 1930s. And then the movie came out in 1943 with Gary Cooper and Ingrid Bergman, still with the title, For Whom the Bell Tolls. But this was a long time ago, and I don't think many of you were born when these things became known. Anyway, I've reflected on this distinction, and one of the questions is, do we wish that people could follow George Bernard Shaw and take the statistics more seriously than their own emotions, their own empathetic involvement? I tend to think it's good that human beings can have strong feelings based on what I might call empathy or sympathy that may overwhelm their ability to calculate probabilities and things of that sort. I get an awful lot of requests for contributions. One of the things I've learned is that if you spend enough in contributions to your favorite charities, other charities learn of your generosity and bombard you with requests. And every time you contribute something, they know that the tax deductibleness of my contribution depends on their sending me an acknowledgement, a written receipt. And always the written receipt comes with a little extra segment in which you can contribute once again. And I notice, more than I used to, that the advertisements, you might call them, the requests, are frequently identified with very touching portraits of hungry children and things of that sort. I brought one, you can't see it, and I didn't make a slide of it, but give a child with a cleft a second chance at life. I've seen dozens of these photographs in magazines as well as in the mail I get, and they all show either a child or 3 children, all with cleft palates. And I have a hunch that they know what they're doing, that they've discovered that the more poignant the photograph they send out, the more money they get in return. And I tend to think that's a good thing. It can be overdone. I have a stepson who recently acquired a dog. The dog was collected off the streets in Beijing by somebody who takes pity on stray dogs, was shipped to San Francisco, farmed out to an animal shelter, and he went to the animal shelter, paid a modest sum, I think, to have the dog neutered, and took the dog home and loves the dog. And I thought, somebody in Beijing has the wrong values, you know. So much more could be done if he or she would subsidize euthanasia for all of these stray dogs, rather than take a tiny sample of them and ship them by air all the way to San Francisco. But nevertheless, I think it's good for the human race that people can respond to these, call them emotional challenges. And I think that I want people like those of you gathered in this room to follow Bernard Shaw's example and take statistics seriously. But I sort of hope that most of the people out there will respond to the idea that children are hungry. Okay, do I take a few questions, or?
Why don't we save that for the panel?
All right.
Well, I think you'll all agree that this was not purely ceremonial, and all of us appreciate the ability of Tom Schelling to think about things in very poignant and new ways for all of us. So let me call Dave Cutler up here.
Well, thank you. This is sort of quite a topic. When Norm first called me and said, they were having a conference on this, I said, "Oh, great, tell me the answer." Then he said, "No. We want you to tell how economists think about this." And I said, "You don't understand. Nobody ever mentions economists and ethics in the same sentence." Except if it's related to the movie Inside Job. In which case they typically don't want it to be that way. So I'm not sure I have anything profound to say, but I'll just give a couple of thoughts, just maybe to spark a little discussion. And like Susan Dentzer and Tom Schelling, my mind instantly went to an example to try and think through this. And Susan went to the ACA and the debate about individual liberty versus social good, and Tom went to helping poor people and so on. What my mind went to was the issue of medical errors. Okay, so there's an Institute of Medicine study that estimated that up to 100,000 people die every year because of medical errors. Now think about what that number means for a second. That's the equivalent of a 747 crashing every day of the year, more or less, with people who die because of medical errors. And so one of the things that has sort of confounded policy, or confounds people, is if it really were a 747 crashing every day, it wouldn't go on for more than 3 days before we shut down the entire airplane transportation system. And yet we see no need to do anything truly spectacular about the 100,000 people who are dying every year, let alone, the Institute of Medicine estimating that 18,000 people die a year because they're uninsured and stuff like that. So how do you think about that, and what's going on? Well, part of it is sort of various cognitive biases. Part of it is that people don't understand magnitudes particularly. We know they don't understand probabilities. When I said 100,000 people a year, my guess is that was not as poignant as when I said a 747 crashing every day. Even though this room is obviously quite well-versed and quite articulate in matters of statistics. So the way that you put it matters a lot. But one of the sort of unfortunate side effects of policy that comes about because of this is that when what you're dealing with are statistical lives, like 18,000 fewer people will die every year because if they have insurance coverage, or 100,000 fewer people will die a year because of medical errors, nobody sort of thinks that you can sort of sell a policy that way. I mean, you sort of try and do it, but you sort of can't really do it. You either tend to make it be about the individual, that is, here's a person who died who wouldn't have otherwise died, or what you do is you sort of abandon that and you say, look, it's hopeless to try and convince people about what's good about this. I just want to do the policy, and then when good things happen, I'll remind them that it was this policy. And so, for example, a lot of, people say, well, why didn't the administration or Congress or whomever try to sell the Affordable Care Act better? And the answer was because I think at some level they concluded that they just couldn't do it, and that the better thing to do was to have it take effect and work, and then come back and say, oh, by the way, it worked, and now you should be glad about that. And that was sort of the lesson that people learned from the Clinton era was that you didn't have to, people didn't have to understand what you were doing. They had to only understand the outcomes, and that the outcomes were in some way better, and then you remind them of that. That's, of course, problematic when you pass a law that goes into effect 4 years later, because then you get to spend 4 years trying to relitigate the damn thing. So it sort of seeps into all sorts of ways. Let me make just a couple of other thoughts about this topic. One is there is actually an economic distinction between a statistical life and an actual identified life, and that has to do with income effects. That when it's an actual life, some of what we feel is, gosh, this person was not rich enough to be able to afford getting that medical treatment that would have saved their life. And so even if I told you that it was sort of in expectation that 10 people would be saved versus in actuality we're going to be able to do the operation or whatever it is for 10 people, the statistical part, you sort of don't immediately think about money. And the actual part, you do wind up thinking about, gosh, it's really a bad sign that in our society, these people are not rich enough to be able to afford this particular treatment. And I think that's, it's not explaining it, but it sort of helps to understand a little bit why people think about the identified life, because it's bringing in more immediate, more than just, the same number of people dying. It's sort of, this is really a reflection about a particular circumstance that I thought society tried to avoid, whereas the statistical life is sort of, you don't feel like someone is constrained by income effects in that way. So just to take an example, the cost of putting an airbag in a car is about $300. Okay, so it's not a very expensive thing. And so, you sort of say, well, look, yes, you can afford to do that. Whereas the person who gets in an auto crash and doesn't have the money to pay for surgery, and the hospital doesn't have the money or whatever, then you're sort of really dealing with, gosh, they're poor, and that's the problem here. So I think that's one sort of issue that's going on. Another thing I think may be going on, by the way, is that there's a sense of accomplishment with the one person that there isn't with the multitude, as people often feel powerless in society, and so it's hard to, it's sort of, we're going to save 10,000 unidentified people, or 100,000 unidentified people versus some number of identified people. You can actually feel the direct accomplishment, which is sort of separate from the income effect but related to it. Where economists have taken this, unlike the policy process, which has basically said, don't worry about it, where economists have taken this is to say, what we really think we ought to do is deal with the statistical life and look at the valuation of statistical lives. So that one we think is more useful. And it's particularly useful when people are spending out of their own wallets to make it happen. So if I go to you and I say, how much are you willing to pay for an airbag in a car? That is, here are 2 cars. I want to know which one you want to buy, and you're going to pay the money for it. Okay, one which has the airbag and one which does not. Economists generally will think that that's a better way to get at it than to say, here's, Cutler, who is in an auto accident, how much will you pay? How much are you willing to contribute to his treatment for the fact that he was in an auto accident, or the equivalent sort of thing. Why do they do that? Not, it's not there's no obvious theoretical case other than the income effect story where you'd sort of think about one as being that different. But we tend to rely on the statistical life as being somewhat more accurate. And one of the interesting things that you note about that is that when you look at market-based studies of statistical lives, sort of how much are people willing to give up in income for small risks to them, not immediate risks, but small risks to them. The range on that from the 20 or 30 good studies, the range on that is not hugely off, is not hugely wide. So you tend to get that people will give up the equivalent of about, I don't know, $3 to $5 to $7 to $9 million for a life. Now that's a factor of 3 difference between the low end and the high end, but it's not a factor of 300 difference. Most economists feel like they kind of have a sense about how to value a statistical life. Where you don't find those results are in public programs, where sometimes we ignore things with very low cost compared to benefits. And sometimes we do things, think about breast cancer screening in 41-year-olds, which have huge costs in comparison to benefits. So the public sector, when we make these decisions collectively, seems to be all over the map. But there's sort of smug complacency that's almost certainly too smug and almost certainly too complacent about these sort of statistical life comparisons. I probably think they're, I think they've got as much errors as anybody, but that's sort of where the field has decided it's most reliable. So that's at least a little bit about where some of this debate has happened. But as I said, I don't think I have a great answer to it.
Thank you, David. I'm going to call directly on Dan Brock to come and establish a moral order among all these remarks. You have slides too. Okay, there's a remote here.
So I'm going to make an assumption that the previous speakers have clarified the notions of identified and statistical lives, and that they have given examples. Now, when I did this slide, of course, it was only an assumption. Now I'll assume that it's in fact true. And I'll call on some of their examples in my discussion. So my question is, what moral or normative reason could justify giving greater value to saving identified lives over statistical lives? And I'm going to have a basic premise in my talk, namely that what I've called the equal moral worth of human lives. That we value, when we think about morally valuing saving lives, we value each person's life independently of their economic or other societal value, and regardless of their social position or stigma. Now, this applies that all else equal, saving more lives achieves more value so long as the beneficiaries are fairly chosen. It implies also that all else equal, and that'll turn out to be an important phrase, identified and statistical lives have equal value. So the defense of the bias to identified lives, which we've had several examples of, the defense of the bias to identifiable lives requires some argument to overcome, in my view, or override this principle of the equal moral worth of lives. And what I'm going to do in the talk is just to go through about 7 possible arguments, none of which convince me, and some of which may convince you. So the first argument is what's common in bioethics talk, what's been called there the rule of rescue. This is a misstatement of it, you'll see, but if you can save people whose lives are imminently threatened, then you have an obligation to do so. This applies to identifiable lives, seems not to apply to statistical lives. Now, this interprets the rule of rescue, notice, once you have this interprets it as a moral principle. The person who actually first formulated it, Al Johnson, some 25, 30 years ago, did not formulate it as a moral principle. He formulated it as a common psychological disposition, an empirical fact about us, that when we can save a life, an identifiable life that is imminently threatened, we have a strong motivation to do so, and we've heard several examples of that. So it's, in fact, what this refers to as an empirical fact about us. That fact has no moral implications in itself. There are empirical facts about us that we would think it's not good to act on, like envy, like aggressive attitudes, and so forth. So if this is to be a moral argument, then it needs a moral argument. It needs a moral argument for its importance. So a second argument argues that really what's at work in people's thinking here is giving weight to urgency. For example, in triage in an ER, in selecting patients for transplantation, it's common to give moral weight to the most urgent patient. And some believe that equity requires this. Now, I think here it's essential to make a distinction between what I have called temporary scarcity and persistent scarcity. In temporary scarcity, what happens is that there's a big accident, a flood of people come into the ER, we don't have enough healthcare personnel and other facilities to treat them all at once, so we take the most urgent patients first, at least if we think they're potential survivors. We do this, why? Because we think we can treat the less urgent patients afterwards, and by doing this, we can save more lives than if we didn't treat the most urgent patients first. So there's no extra weight needed to identified lives here, those that are most urgent. It's just a way of saving the most lives possible. Now, in persistent scarcity, by which I mean that the scarcity doesn't disappear, if you like. Organs for transplantation are an example of persistent scarcity, but so are a lot of other healthcare resources because of limited economic resources. In persistent scarcity, giving weight to the most urgent patient doesn't in fact result in saving more lives. It just determines whose lives are saved, namely those that become most urgent at the time at which resources are available to save lives. So why those are going to be identified lives. Okay? So why priority to who happens to be, this is a moral question, why give priority to who happens to be most urgent when the opportunity to save happens to arise because we get resources, we get a new organ for transplantation. And the resources and ability to save in the healthcare context are in fact examples, in my view, usually of persistent scarcity, but when they are of temporary scarcity, we don't need to give more weight to identifiable lives. All we have to do is act on a principle of saving most lives possible. Third argument, I've called it non-aggregation. Norm wrote about this 20 years ago. When you get as old as Norm and I, everything you said 20 years ago. Here's a way of thinking about the identified versus statistical case. The identified person at imminent risk of death gets a huge benefit from being saved. His life continues, whereas it wouldn't otherwise have continued. Identified persons in a group of 1,000, each of whom is at 1 in 1,000 risk without a preventive intervention of dying, they, we might say, each get only a very small benefit, namely a reduction of a risk of death of 1 in 1,000. But now notice, this is not a comparison of identified and statistical lives. This is identified versus identified lives. The one identified person who's at imminent risk and the 1,000 persons who have a 1 in 1,000 risk that's eliminated with a preventive intervention. Now, note something important here. One of the difficulties in the arguments that I'm taking up, which I haven't made explicit yet, is how well do they map onto the identified versus statistical lives comparison? And in many cases, the difficulty is that they don't map on well. So that even if you thought some of these moral considerations are important, they still wouldn't themselves justify the difference between identified and statistical lives in itself because they don't map onto that difference. So one might say here, well, shouldn't we aggregate these 1,000 very small benefits, and then they have the same weight as saving one person at imminent risk, right? 1,000 each get a 1 in 1,000, a reduction of 1 in 1,000 risk of death. Now, for the, as I said, this is identified versus identified. So we might say, for the identified statistical case comparison, what the comparison must be is with unidentified statistical single person among the 1,000, that one person who would die without that preventive intervention. Then we have a statistical life which will be saved. We just don't know which person among those 1,000 it is. Now, the benefit to her, though, is equally big as it is to the person who is now the identified life. So this doesn't raise the issue of aggregation. We don't need to aggregate. We just look at who would be saved, though we don't know who it is. Fourth argument. It's common in a lot of work in distributive justice, certainly in the healthcare sector, to say ethics requires priority to the worse off. And it would seem that a person who's imminently dying and needs to be saved is about as good an example. Can you just give me a little water? It's about as good an example as we could have of someone who's worse off. Now, basically, whoop.
Gave you more than you want.
Right, well, you just didn't give me all in the glass. Now, this makes the same mistake as the non-aggregation argument. It assumes that the benefit of prevention in comparison to the badly off person who's at risk of imminent death, it assumes the benefit of prevention to each is very small, but the statistical benefit of prevention to the one who would otherwise die is just as great as the benefit to the identified person. An interesting thought occurred to me, which I think can't be sensible, but it occurred to me while I was doing these slides, which is, could one argue there's actually a greater benefit from prevention than from treating the identified person who's at risk of imminent death? Why? Because there's a reduction of 1 in 1,000 risk of death to the 999 who wouldn't die anyway. We just don't know which ones those are. Plus, you save the life of one who would otherwise have died, and then that's the full value of saving a life. Now, there must be something wrong with this. I'll leave it to discussion to say what's wrong. That would tell us to give a priority to prevention and not to identified lives. Fifth argument, the appeal to uncertainty. It's generally more uncertain when one looks at real comparisons of statistical lives and identified lives. It's generally more uncertain that one will save a statistical life. For example, preventive interventions that will save lives, say 20 years down the road. Well, maybe a cure will be found for that particular disease, and so we won't need this preventive intervention that we're doing now, and so forth. A couple of difficulties here. It may be very uncertain that one will succeed with saving the life of a person who's imminently at risk of death. People who come into the ER in adverse circumstances, some of them live and some of them die. So it may be very uncertain that one will save the imminent identified patient. And it also may be the case that the success for a statistical patient from preventive interventions may be highly probable. It often is in statistical interventions. It's just not clear who that will be. So again, here, uncertainty does not map onto the identified versus statistical distinction in any reliable way. The second point here is that in comparing saving expected lives, which is what one should be comparing, that are saved, say, from treatment versus prevention, the uncertainty's already been accounted for when one makes the estimate of expected lives to be saved by, say, an acute care intervention and a preventive intervention. So one doesn't have any basis for more weight to be given to the identifiable lives to account for uncertainty. That would just be double counting the uncertainty. A sixth argument, I think I've only got 7, so be patient, is an appeal to temporal discounting. The prevention benefit, the benefit in preventive programs often comes in the distant future. It's standard in benefit cost analysis or in cost effectiveness analysis to discount both benefits and costs. And if you do so at standard rates of 3%, 5%, if you do so, 100 lives saved in 20 years will produce significantly less value than 100 lives saved now. Now, the issue here is whether health benefits should be discounted. Set aside the economic costs and economic benefits, which I think should be discounted. The issue is whether health benefits should be discounted. If you do so, clearly, as the example I've given you shows, if you do so, it will result in saving fewer lives than one could have, right? Because one will not save 110 lives in 20 years, because when you discount those 110 lives, they're fewer than the 100 lives you could save now. But I think one needs an argument for deciding why future lives should have less value or importance than contemporary lives. Where discounting really comes into play and has a big effect is not so much healthcare, but environmental contexts. Because environmental cases, for example, think of nuclear waste disposal. Now the risks may not be to, that one is trying to prevent not to somebody 20 years from now, but somebody 400 years from now. Because the risk may carry over into the distant future. And Derek Parfit is famous, I've never checked the calculation, so I'll assume it's correct. Derek Parfit is famous for having calculated that if you use a 5% discount rate, which is higher than often is used, in 400 years, 1 billion lives are of fewer value than 1 life now. Now, one certainly doesn't want a methodology that gives you that result, it seems to me. I'll leave it open how one gets around it. Seventh argument appeals to special relationships. This is a context in where we do believe that it's justified to give special importance to particular lives, namely those with whom we're in a special relationship. And the standard example is our family members. Most of us believe that it would be justified, or at least permissible, to save your spouse or child instead of 2 strangers. Consequentialists, I think, will end up rejecting this agent relativity, but most of us, in fact, believe it. The difficulty here is this just fails to map onto the identified versus statistical lives difference. The identified person may be a stranger, where there's no special relationship, and the special relationship may be with a statistical group with whom you do have a special relationship. For example, your fellow countrymen, your co-workers, so forth and so on. So here's the conclusion so far. Each argument that I've considered, and about as briefly as possible, so there's a lot more to be said about any of these. Each argument that I've considered so far, I think, aims to show that the statistical versus identifiable lives distinction is in itself morally significant, because it appeals to these other things like special priority, the worst off, and so forth. One difficulty is that these other arguments seem themselves, some of them, not morally significant. And the second difficulty is where they do, they don't map onto the statistical and identifiable difference. So here's, to finish up, a different kind of argument. Giving more weight to identified lives in practice, as opposed to just thinking about the difference in itself, giving more weight to identified lives in practice creates greater overall value. For example, it enables us to save more lives. And that's here now going to be compatible with assuming that each life has equal value. A couple of examples. Donors will give more resources for HIV treatment than prevention. Paul Farmer, my department chair, has shown the truth of that empirical claim. He has, what I think Norm mentioned, 2 wonderful slides of a patient who looks like he's about dead, if not already dead, and then that same person, very healthy and after treatment. That motivates people, as we've heard in all the discussion so far, that motivates people to respond in a way that telling them about the benefits of prevention doesn't. So here, giving greater weight to treatment isn't because a treated life is more valuable than a prevented life. It's because it results in more resources and so enables you to save more lives. Second example, if we have to stand by and not save when we could, many have argued this would be dehumanizing for us. It would erode important moral motivation, and it would have over time bad effects. Now, all of these arguments depend on the truth of the contingent moral claim. And in fact, in many cases, it is true. They don't tell us that an identified life is more valuable than a statistical life. They tell us that in practice, giving more weight to identified lives may, in many contexts, give us more resources or enable us in various ways to save more lives, each of which has equal value. So the conclusion, when that claim is true, we have good consequentialist reasons for favoring identifiable lives in practice. What this form of argument doesn't show is that the distinction in itself between an identified life and a statistical life is of moral importance. There may be other moral arguments that do show that, or I may be wrong that the arguments I've very briefly considered fail to show that, but that's the conclusion. Thank you.